Thank you for introducing me to this wonderful group. And I know that I was given the title of the 10 Commandments, but I came up with 30. I actually did cut it down to 10 because I only knew I had 20 minutes, and I hope I have a few extra minutes. But I don't really feel like I'm the Moses of the Cath lab to put up commandments. But I do think that over my years, I've been thinking a lot about what are the things that we should be paying attention to in order to be successful in the Cath lab, especially for the trainees. And I started writing a book that I will finish when I retire, and the book is called I Blew It. And in that book, I have a lot of chapters, and many of those chapters actually fall into these commandments. So I actually thought it was fortuitous to be asked to give this lecture. So that's, you guys are familiar with the movie, The 10 Commandments. I actually thought of dressing myself up as Moses to give this talk, but I didn't think I should, so I didn't. All right, anyways, this is my disclosure, and let me just start. Now, when you're in the Cath lab, we all have a goal, right? And what is our goal in the Cath lab? Whether it's therapeutic or interventional, the goal is to produce a safe and effective procedure, right? So it's really using these two words, the safe and effective, as the mantra from which to develop those commandments. So again, now of course we have the hybrid procedure that includes our surgeons, and that also adds another element of thought for what are important parts of that. All right, let me start with commandment 1. There are many, actually I did take those 30 commandments and lump them, but many are lumped into 1 and 2. So these are the major ones. The rest are a little easier. You hope for the best and prepare for the worst. Now that's your mentality more than anything else. But you have to prepare for the unexpected. You have to treat each patient according to his or her unique cardiac anatomy and physiology, and then you anticipate any potential complications. Your complications can happen in the procedure, after the procedure, extubation, oral intake, for example, vascular access, bleeding, occlusion, infection potential. Also, there are complications we often overlook, like allergic reactions. We don't think about them a whole lot. Brachial plexus injury, depending on how you hold up the arm. Again, in adolescents that are muscular, I've had a few of those that ended up with a brachial plexus injury that we had to go send to physical therapy. Vascular injury, as mentioned. We also have to think about radiation and contrast use. And of course, in the young babies, they're going to have a lifetime dose of radiation that you have to consider and think about. Keep up your guards. I'll show some examples of this. The other thing I say to my fellows is that if you don't look for it, you won't find it. If you don't expect it, it will find you. So learn to look for things and expect things. Okay, this is a saying that I learned from somebody, I don't know who started this. If you know that you know it, you have your confidence. If you don't know that you know it, it'll come back to you in emergency, and that should be fine. You'll recall it. If you know that you don't know it, you will get prepared. The worst is if you don't know that you don't know it. That's when you get burned. So the key thing is trying to minimize that quadrant in space in your brains. Minimize those things that you don't know, and that's what you have to prepare for. So you always have to have a plan B and a plan C. I'll share a little story first. I worked in 2 major centers for about 20 years with probably the 2 most dominant, self-serving, crazy surgeon in Texas Children and in LA. And we fight for all these cases. Oftentimes, I felt that the surgeons were treating me as an adversary, as somebody who would steal their cases. In fact, one actually said to me, "Why are you cannibalizing my cases?" So every time we did get a case in a lab, I had to be very sure that I had to have a safe result. And that was not fun because it was stressful. But the only silver lining that I've realized is that it really made me to become a better interventionist. I had to make sure that the procedure went well and that there were no minor complications because that would come against me. So again, the good thing is that in that stressful, adverse event, you will find ways to grow and develop more confidence because you're going to come up with better things and more safe things to use in your armamentarium. All right, I'm going to keep going. If you don't look for it, you won't find it. Sorry, I'm going to jump. Always have a plan B and even have a plan C and get really familiar with the patients and your history. such as the comorbidities, the specific vulnerable cardiac anatomy, such as coronaries in a Williams syndrome, or pulmonary atresia, or patient have pulmonary hypertension, or failing Fontan. These are things that keep my guard up to say, I better pay attention to what's happening to these elements, because you never know when things go wrong. Get familiar with the supplies, sheaths, wires, catheter, especially retrieval devices, and practice using them. I always tell my fellow, when there's a snare that's been used, tell them to take it and sit down, and when you have a boring lecture, hold it under your arm, don't let anybody see it, and just practice. Then you learn how to control the snare with the catheter, and you'll get good at it. Never say it's just. I know people say, oh, it's just a PDA, and then they get into trouble, right? So never use the word just. You'll just get yourself, you'll drop your guards. All right, so here's just some of the retrieval devices that you need to learn. You can actually make your own. See the last one? This was just a 4-French catheter. We take a 1-4 or 1-8 wire, loop it on itself, run it through, and you can make a snare out of yourself, make the angle you want, and you can get yourself out of trouble with a homemade snare. Much better than some of the products, depending on the anatomy. All right, so if you don't look for it, you won't find it. Have a high index of suspicion. Be persistent at looking for anomalies. Do selective angiograms to see what's going on further in. So here's an example, and I'm just going to throw it out once, and you guys say, what's the diagnosis here? Because of time, I'm going to have to tell you what it is. So you notice that the frame on the right, this is PAPVR with a lower right pulmonary vein that drains to the IVC, right? You see it very down in the levo phase, right about there. And then, of course, you see this collateral that's going up to that right lower lobe. It's the scimitar syndrome, right? So you see that. Again, you have to pay attention to the levo phase. Don't just get caught up on the more obvious parts of the contrast. What else is wrong with this picture? Most people would miss this. Somehow the AET tube kinked, and nobody paid attention to it. So these are things that can get you into trouble. So be very observant. Think about the whole picture, not get too focused on one thing. What's wrong with this picture? Now, this is a pre-Glenn Cath. It's heterotext, you can see. Again, not going too fast into this. I would have pushed the fellows to give me an answer. But what's wrong with this picture? You see the IVC go up, and you see contrast refluxing into the right hepatic veins. Whatever the forces that are making that contrast go to the right, why do we not see the left? And of course, if this patient went to the surgery for the Fontan, the surgeon's going to basically hook that up, thinking everything's fine, until you realize that there's actually a left hepatic vein that's draining separately. Again, if you don't look for it, you won't find it. Have that suspicion, especially in the heterotaxis. Pay attention to that. Another one, this is, I borrowed this from one of my colleagues when we were working together, Chris Pettit. You see this angiogram into the left pulmonary arteries. Again, I'm going to go quickly. He basically was not seeing the left upper pulmonary artery, and again, it's important to do selectives. He takes a picture here, and you notice the contrast actually does not go into the pulmonary veins. It drains into the lower pulmonary arteries. Well, why is that? If you watch the levo phase, there's pulmonary vein stenosis. Right there. Point it one more time. Right here. Again, if you miss this, you won't have a chance to fix it. So this is just the things that you're paying attention to, looking at the levo phase. Don't look at the obvious. It's the less obvious that becomes important. All right. So anticipate potential problems, events, and complications. Here's an example of a 2-month-old TET with absent valve and had an LPA stent. Now, if you were to put this in, technical success, what's the next step you would do? Great job, let's extubate, send home. Well, you all know that these kids, we should be anticipating something. That is reperfusion edema, right? That lung has never received blood, if the duct is gone, and suddenly it comes back. So there's the pre, 3 p.m. after that, 8 p.m., the entire left lung is whited out. So if you were to extubate that kid and send them home, or even not send them home, this kid would be getting into trouble at this moment. So just be aware that this type of lesion, you got to keep them extubated and anticipate that there's going to be reperfusion edema. It's a complication, but it is a necessary complication for this anatomy. I wonder if the surgeons here would recognize this problem. All right, I'll just show it to you. What are those, where's the red arrows pointing to? Anybody see? somebody left a suture needle in the pericardium. I saw this in the Cath, and I said, this kid has had multiple x-rays before. It was never reported in the x-rays. But again, this is just paying attention to everything around you. When I was training, my mentor always says, don't pay attention to systolic murmurs, because that's the obvious. Listen to the heart sounds, listen to the second heart sound, listen to the diastolic murmur, and then listen to the systolic blast, because that's the obvious thing. Think of everything else before you think of the obvious. I went back to the surgeon and told him, and he sort of sheepishly realized that he saw it. He didn't tell anybody. I just thought it was interesting. All right, commandment number 2. It's not over until it's over. So like I said, don't let your guard down after successful intervention. It's not over until the wire comes out. It's not over until the patient gets extubated. It's not over until you get your follow-up x-ray or echo to show that the device is stable and there's normal hemodynamics. It's not over until the patient gets discharged. In fact, it's not over even after it's over. We have to think of small kids, their lifetime strategies, not just the present. I find this a flaw when we take a small baby stent and put it into a baby and it looks great, only to find out that 5 years later the kid has outgrown the stent and now you cannot get the stent to the size it should. So do not think of just the present. In grown children, you got to think for lifetime strategies. I always say you are responsible for any device implanted for the lifetime of that patient, and you are also responsible for late complications. So we have all seen these vascular stenoses after surgery, cath, or just central lines. But here's one where I remember doing this patient with a fellow. He accessed it, and next time I felt a little bruise in the groin. So we had to take him back to the cath lab because we were suspecting this. It's a AV fistula from where this site entry was. I'm sure the fellow went through one vessel and then to the other and then created this. But these things can happen even for what is just a PDA closure. So of course we have to deal with it. And here's just some of the images you see of some of the other ones where you end up with, for example, this giant venous varix, and some of them can actually compress into the bladder. So these things are important. They happen afterwards, after you think you've had a good outcome. There's another routine PDA, and I borrowed this from one of my colleagues also. This is what the IVC looks like after the PDA. He struggled through this. And again, this should never have happened. But again, these are the complications that you can encounter in spite of a technical success. Small patient arterial angiogram looks good, but you notice how small the iliac arteries are, had hard time coming out, and eventually you end up with this. Luckily, there was a wire there, and they ran in and put a covered stent in. Here's a tetralogy with prograde access to the aorta for ductal stenting. Afterwards, we created mitral regurgitation. Again, I never forget my mistakes. These are the kinds of things that we have to remember and continue to learn and make sure that we don't repeat these again. I think I showed this already. You have an isolated PDA, and you end up with a nice result connecting a PDA to the left, and of course you get with this pulmonary edema. I showed that, sorry, I didn't have to repeat that. All right, it's not over until it's over. Again, we've seen this one. You put a stent into the LPA in the Fontaine, you're happy with it. As you pull the balloon, guess what? That stent is sliding outward. And of course, I got called in to get help, so we end up taking that balloon, further dilating it, and gently bringing it down to the IVC, and we just left it there. It's a safe place, but it wasn't useful for the purpose of that. There, if the stent was in good place, but when the balloon was pulled back, it dragged the stent out. And if you watch these balloons, and I do this in the cath lab, I will save expired cases, just look at them and see what happens. I'm deflating this. Look what happens when we deflate that. Now, when it comes out, originally in the package, it's very well wrapped and it's got low profile. But when you deflate a balloon like this, it doesn't wrap up all the ways. So suddenly you have a big wing of a balloon after deflation, and you can imagine when you're pulling this out, this is going to drag the stent out potentially. Same thing with this one. The top is inflated, deflated looks like a sailboat. So therefore, you have to pay attention to removing balloons after you're done, and do not let your guard down for that. There are a couple of tricks that we can do to prevent that, but I don't have time for that right now. There's a PDA stent. One of my colleagues, Henry, when I was in Houston, same thing. PDA stent, great result. Stent went in, and then suddenly he had trouble pulling the wire out. He had forgotten that he had twisted the tip of the wire so that it locked into the pulmonary vessels in order to give him counter traction. And now suddenly, he's happy here, but he's pulling and he cannot pull it. And eventually, this is what it looks like. He's pulling, and that PDA now has become occluded because he could not get the wire out. This is what the wire, he went to surgery, and this is, basically he stripped the wire. So pay attention to those wires you use. If you're going to twist it to give you counter traction, make sure you untwist it, and make sure you remember whether you start as clockwise or counterclockwise, because you can make it worse by making it go the same direction. So these are things that you have to think about even after you're successfully did your intervention. It's not over even after it's over, right? Here's an example of a cohort who put the stent in, thought it was great, come back 2 years later, and now there's an aneurysm. I scratched my head on this, and again, I've always made a practice to go back and look at old things to see if you can learn anything. Obviously, we're able to, well, actually, this is the one film picture we took at the last case. You notice there's one strut that looks like it's sitting right outside of the space. And again, that was also where the aneurysm was located. Luckily, we had a cover stent, we fixed it. But these are opportunities for you to learn from the mistake and pay attention so you don't repeat that the next time. Sometimes you can't avoid it, but now you're going to be much more careful in watching this kid. All right, melody valve, great case. Was a college student. This is early on. She has the valve. She goes back to college, went to the dentist the following week. And then next thing you know, she comes back with fever. She actually went to a school in another state, came back, and of course, this is just endocarditis. So since then, we've said everybody who gets a valve, you got to get dental clearance. We need to see the dentist say that you don't have any more cavities before we put the valve in. Again, that was very early on, but we learned that lesson quickly. You might ask, what's wrong with this picture? And I see this commonly. Nothing is wrong with this picture, but if you're focused on the heart, why do you need to show the liver and everything else around it? So when you cone down and you cut all the corners, you have not changed the value of your angiograms. Now remember, we're thinking about lifetime radiation for the patient, right? So nowadays, when I sit back and I see somebody's angiograms, I see half the liver on the film, I'm thinking to myself, that kid's getting way more radiation than you need. So look at the liver when you take your pictures. If it's there, you can cone down and save a lot more radiation to the patient and any reflective radiation to yourself. So you see, this is no different. Your value of this angiogram is no different than what you saw when I showed you earlier. So be aware that you're providing part of that lifetime radiation. Commandment 3, you learn fine strokes. The broad strokes you should already know. It's the fine strokes that you really need to learn. I used this last time. Things like anatomy is important. Accurate measurement is important. Pay attention to the flow. And then, of course, look for levo phase, where you look for pulmonary veins, for example. Look for washouts, dual perfusions. Pay attention to the density of the contrast, the extrinsic compressions, any radiolucent mass or thrombus. Pay attention to dynamic changes. Are there folds, kinks? Pay attention to changes in the orientation of the wire against the native angles. Be aware of native angles, curves, and tortuosities, because they change, like Sebastian said, when you put a stiff system in. Stiff wires can alter those shapes, and they can also then return to the normal shape after you remove it. Pay attention to hemodynamics, serial gradients. Levo phase is important. Know your adjacent anatomy in the area of interest. You got to have a situational awareness where the wire position is, how it's angled, how it changes the native anatomy, the risk of arrhythmia, and then pay attention to calcium. You know, we all have the Carpenter rule: measure twice, cut once. Do not compromise on good wire control. These are all fine strokes that we all need to learn. Beware of thrombotic events. Develop good techniques. We all say that techniques can compensate for the lack of tools. But tools do not compensate for the lack of techniques. So you have to learn good techniques. Avoid making complication. Again, there's this art of making things look easy. Fine strokes. Here's an example of this. I'm going to go back. This is a sketch. Now, the broad strokes are like a sketch. You want to be a sketcher? Great. But if you want to be a master, you need to learn the fine strokes. And that's what will separate you as an interventionist over the next person. So think over fine strokes. Here's an example of a case where there is a stenosis in the LPA, and I'm just drawing out the angle. And as soon as we pull this wire out, watch what happens to that stent. That stent goes back to its native angle. Now, in this case, it was fine, but had that stent been further in, you can imagine it will obstruct the gland as it comes out. But you might not be aware of that until you took the wire out. So pay attention to native angles. This is just an example showing how your wires can have tiny little angle changes. And sometimes I will actually look at it and help me angle it properly to get to where I need to. This is a good example. I'm just drawing out the infundibulum stenosis, this in a TET. So you look at this and you say, okay, great. We put the stent in here, and the wire is still in place. And if you look at this, after the wire is removed, you notice that something changed. You notice that the angle of the stent had changed. And that's because the stent went back to its native angle. And as it straightened out, guess what happened? It fell behind the infundibulum. Now suddenly you have a residual stenosis. Now at the time, that stent looked really good, right? Looks like it's in place until it straightens out. So if you were aware of that, the fact that you had changed the angle, you might have put your stent a little further just to make room for this shift later on. These are the things that you need, these are the fine strokes. Know the native anatomy. You have to anticipate how the device changes the shape and make room and adjust for that. So, fine stroke, essential to have accurate measurements. I've talked about this in the past. Here's a PDA. Which is the real diameter? That frame or the one frame or the other frame, right? Look at the minimum diameter change depending on the cycle. Many of us will stop on the frame with the most contrast because that's when you see the most contrasting edges. But that's not always the frame that you need to make sure you got the largest diameter, for example. And that's really important. So don't pick the frame with the most contrast. Pick the frame with the largest diameter that you're going to close. So here's an example of another PDA that looks pretty compliant, flexible. There's just 3 frames, one after the other. This frame, this frame, this frame. Now, if you look at the first frame, that has the most contrast. So if you were to measure that, you might measure that part of the frame to say, okay, this is where I'm going to measure my diameter. If you look at the next frame, suddenly that diameter has a larger minimum diameter compared to the first one. Well, are you going to pick the first or the second? You really want the largest minimum diameter because that's how you pick and choose your device. But now look at the frame afterwards. Your aortic ampulla is also different. So sometimes when you're making measurements, you might have to make measurements on one frame for one thing, another frame with another measurement, so that you pick out all the best features of that anatomy based on wherever part of the cardiac cycle. So don't always just use one frame, because that way you'll know the anatomy and you'll pick the most appropriate device. Another example of a coarc, you notice that the ascending aorta on the lateral pulsates, right? And so that's what I'm looking at right there. So if you take this frame, you'll measure 10 millimeters. If you take this frame, 12 millimeters. Now, can you imagine putting a 10 millimeter stent in a vessel that could go to 12? That's going to embolize or risk embolizing. So you have to pay attention to these compression, dynamic things. Your end holes are always a worry because you can almost trap air in there as much as you think you can pull back the air. So here's an example where we shot air. Now this is going up the vertebrals, which is not exactly a good thing, right? So these are errors that we can avoid, but we have to pay attention to these fine strokes. ST changes on an ASD closure. I'm sure I shot air into at the time. So these are careless things that we have to pay attention to. And one of the days I pulled out a clot out of the delivery system. A small preemie baby, closed the PDA, thought I did a really good job, and then somebody's on echo said, what is that thing in the RPA? At the same time, I saw this little radial density, lucency right there. That's a clot. I shot a clot through the catheter after we closed the device, and the echo showed it too. And so you can almost see this is the clot right there. And then, of course, luckily, we put them on heparin, and a day later, it resolved. But then, since then, I've learned I would never take a picture after. I would just use echo to rely on the positioning. Another clot from taking care of a renal artery stent, you can almost see that clot goes up to the upper pole right there. And in fact, it blocks the forward flow of contrast. So the contrast is stuck in there. We end up giving them heparin, and we're able to resolve it. But these are the things that you have to pay attention to avoid complications. Respect calcium. That's really, really important. When you push against calcium, either it will crack or your balloon will crack. Either way, you can lose, right? You can just picture that. Respect resistance. Anytime you put on something, if there's resistance, something is wrong. You develop a very sensitive touch. When wires and catheters don't behave as you expected, there are only three things that can take place. Either you have bad technique, you chose the wrong catheter, or there's something in the anatomy that you're not that familiar with. So take a picture. That's from my lab. So here's just a picture showing a nice eggshell type RVOT, and of course, one of my senior mentors back in Houston cracked it, and this won't run, but basically it caused a dissection, open dissection. So calcium will crack, but you don't really want it to crack in a way like this, right? So you either lose or you lose. So here's bilateral branch PS, and again, this is early days when I was trying to figure out, I was aggressive, double stenting here on a calcified area, and oops, and you notice that one of the balloons cracked, had a pinhole when we finally inflated it, and now I'm stuck. So at this point in time, I'm taking out my catheters, and I noticed that after I took out the right, there's still radial markers inside there, meaning that I know I had torn the balloon off. So this is the only one in my career where I had the surgeon help me with an emergency procedure. He took out the stent, and of course, you see the broken balloon, and then he pulled out some of these calcium spicules just to prove my point. I've learned a lot. I've learned to respect calcium. This is some of the calciums you might see in the old pipe, and they can be very sharp, and you can picture how they can break your balloons. So respect calcium, again. Almost. Okay, you know what? I can stop. Let me just do one more, and I'll stop. I'm so sorry. There's so much to talk about in terms of commandments. I'm sorry. Okay, so just that when the wires don't go easy, don't just push, because the wires will get you into trouble. So when it does, once it's in, you guys know it should feel like butter going in. If it doesn't, that means there's potential trouble. So I would say that, here's a case I got called in to get some help. This is actually the wire position. Anytime I see a corner in the wire, I know somebody was pushing too hard. This is what was pulled out of it. You see the fraying at the tip of the sheath. So again, sometimes some people would just push and push until it actually goes to another part of the body. And in this case, it was a 10 French sheath trying to get a wire up there for the purpose of a valve. And we ran a glide catheter up there just to protect the sawing of the wire, and eventually was able to get it out, and at least there was no further damage. And you see the wire out there. I'm going to stop here. Invite me to come back and do the second part of this, because it's important. All right, thank you for your attention.